Associate Professor Jamus Lim.
Not long after I landed on US shores for my doctoral studies, a week after September 11th, 2001, as it turned out, I had to confront the behemoth that was the US healthcare system. One of my earliest tasks on arrival was securing medical insurance. Because I was a graduate student, I was enrolled in a plan managed by the university. The amount was non-trivial, especially for a student confronting US dollar exchange rates. But in exchange, I was able to see the doctor at any time without paying any fee, including for routine illnesses such as cough or fever, while also enjoying fully paid dental and access to world-class hospital facilities and surgical procedures. I was only 25 then, of course, and like most pre-chronic condition 25-year-olds, I thought I was physiologically invincible and I would never need a doctor. Still, the insurance plan was mandatory, and so I reluctantly signed on. After spending a dozen years embedded in the US medical system, I've come to understand just how painfully convoluted the system was. The University of California healthcare plan, which I had previously been under, was, as it turns out, a relatively good one. In contrast, many plans are far less generous in their terms and costlier to boot. And if one were to lose one's job, one would automatically lose one's health insurance, a painful double whammy of being both unemployed and uninsured. And in contrast to my free-of-charge visits to the university health center, most insurance plans charge a copay per visit, which could amount to $30 or $40, the amount that I would pay out of pocket for any doctor in Singapore, even without insurance. Why am I sharing this story? Because I used to think that the Singapore system, where we were assured of world-class medical care at a fraction of the cost, was an amazing healthcare policy success. Singapore managed to contain costs, all while generating impressive and still improving health outcomes. We appeared to have cracked the code of healthcare financing. At the global level, our healthcare costs do remain admirable, prompting the New York Times to question in a fawning article as recently as 2017, what makes Singapore's healthcare so cheap? I'd often attributed this miracle to a combination of Asian veneration of doctors as a calling, our scholarship bond system that kept junior doctor salaries compressed for a half-decade out of medical school, and the dominance of a largely single-payer, publicly run, broadly universal healthcare system. But over the years hence, our model has begun to edge ever closer to the mixed system that characterizes the United States. And I'm not entirely certain that this has been a positive development. Mr. Speaker, I contend that focusing solely on preventative care is an incomplete solution to limiting the demand for healthcare, whose persistence has indeed been driving prices up. The solution our people face today must go beyond healthy SG initiatives, as laudable as they are. Healthcare costs are escalating, are doing so rapidly, and look to continue to do so in the future. Even without greater attention paid to prevention, we must not limit ourselves to outsourcing yet another initiative to the end user without simultaneously tackling issues inherent to the system. Singapore's healthcare financing is often described as resting on three key elements: MediSave, MediShield Life, and MediFund, which together with subsidies characterize the idiosyncratic Singaporean model. But it's also worth noticing that these three vaunted pillars of the system finance only a little more than 8% of total national healthcare expenditure. Including subsidies, this increases, but not by all that much. The upshot is that beyond the 3Ms plus subsidies, we cover a significant amount of expenditures directly out of our own pockets and savings. As a share, but even though out-of-pocket expenditures as a share of total expenditures has fallen, the absolute amount we've had to pay has steadily risen. Dollar spending on out-of-pocket expenditures, even after accounting for inflation, has almost doubled over the past 2 decades, from $448 in 2000 to $821 in 2018. This eats into our real income gains. Over the period, increases in healthcare costs outstripped inflation at a rate of 2.3 per annum to 1.5%. Perhaps more worryingly, other independent sources peg much faster price increases in the future, between 7 and 10% per annum in more recent years. Every month, Singaporean families spend an average of $323, or 5.5% of their incomes, on health expenses, an increase from 4.9% just a decade ago. Such spending was as much as families set aside for education, and more than communication, clothing, and footwear, and recreation. Moreover, this share has been growing for the least fortunate among us. While the highest quintile of income earners devote 4.8% to healthcare expenditures, the burden on the lowest is more than 1.5 times greater, at 7.8%. While dedicating a little bit more than 5% of each paycheck to health is surely a wise investment, the concern is that this could continue rising. Spending a few $100s monthly may still be manageable, but this becomes much harder to bear when the amount begins to approach $1,000 every month, or more than $11,400 a year. Is this an impossible fantasy? I hope so, but it's worth noting that American households currently fork out an amount comparable annually, and they used to pay our current share as recently as 15 years ago. Now, the issues of how informational asymmetries are endemic in markets for healthcare and health financing are well understood by members of this House, and I shall not regurgitate them here. The main takeaway is simply that we cannot expect we cannot expect healthcare markets to function in a similar manner to other markets, which necessitates some degree of government intervention. One important corollary of this result is that while we may very much wish to harness market forces to contain price increases, we need to be very judicious in our application of such mechanisms, because introductory economic principles may give rise to counterintuitive and perhaps even counterproductive outcomes. I will document several examples of such outcomes when I deal with potential solutions later in my speech. Another important corollary is that any policy that increases the distance between the patient and the payee may also lead to perverse outcomes, because this distance separates agents, patients in this case, from the cost implications of their choices. This could be on the part of healthcare providers if doctors are primarily making treatment decisions with little input from the patient, or from healthcare financiers if health insurers are defining available options or covering all costs involved with little feedback from the insured. While some gap is inevitable, I would have no idea how to choose between one treatment regimen versus another. But the more information we put in the hands of patients, the better. The suggestions I will detail also account for the importance of keeping this distance as far as possible to the minimum. Moreover, public healthcare often coexists with a vibrant private sector. As the pandemic has reminded us, public health is, in and of itself, a valuable public good. But the private market for healthcare often plays an important complementary role in the overall national healthcare system. In developing countries, the emergence of a parallel private system is what often prevents an outright collapse of the overstretched public system altogether. And in advanced economies, the private system can plug gaps in care that the public system is unable to meet. Managing the COVID-19 pandemic would have been much more challenging in the absence of private healthcare. Nevertheless, while there is seldom an optimal division of the appropriate proportion of healthcare provided by the public versus the private sector. Resource limitations in the former usually means that it tends to ration by time, either a longer wait before an operation in a public hospital is scheduled, or a shorter time spent with the doctor at the polyclinic, while the latter, the private system, controls demand by price, which is why one tends to pay for the privilege of speed and attention when seeing a private doctor. These differences are not problematic per se, as long as we recognize that they're also essential trade-offs. However, we should never allow these trade-offs to become a synonym for quality. Indeed, many of my doctor friends, including those in private practice, suggest that complicated procedures could well be best performed in a public hospital in Singapore because they are endowed with the latest technologies and tend to see a greater volume of complex cases and hence acquire familiarity and expertise in dealing with them. So before I touch on some suggested refinements to the current system, I will stress this at the outset. Promoting competitive forces are often a positive and a means of containing costs. However, we want to exercise care when we apply regulation in service of promoting greater competition. For instance, price fixing or collusion is typically frowned upon because this allows suppliers to coordinate on a price target, which would otherwise be unsustainable in the presence of genuine competition. But such prohibitions may only make sense when the competitive landscape itself is characterized by few players in possession of substantial market power. When there are many suppliers, coupled with free entry, firms are much more likely to compete on product differentiation rather than price. In this case, even when doctors can freely set prices, excess profits are no longer assured, at least in the long run. Prohibitions on price guidelines, in this case, may merely induce market participants to pursue greater differentiation through the inclusion of bells and whistles, which could paradoxically elevate their costs and, in turn, prices charged. Hence, the decision by the Competition Commission of Singapore to prohibit price guidelines issued by the Singapore Medical Association, or SMA, may make sense insofar as we are looking at a market comprised of a small number of providers. But this hardly describes, in general, the physician market. It would seem to me that regulating the price schedule per se, with the inclusion of a wide range of representatives, including academics and Ministry of Health appointed doctors and medical professionals, as has been implemented by the MOH fee benchmark, would be better than allowing prices to be completely unmoored from any guidance whatsoever. What remains is to have all prices cross-reference to these benchmarks so that incentives to adopt them will remain compelling. One approach is to require all physicians post a multiplier of their charges relative to the benchmark's median. Benchmark ranges should also not be allowed to drift too wide. To prevent a proliferation of procedures, fee ranges should be posted for just the most common ailments, not surgical procedures, since the latter are often less relevant to the typical patient. These should be prominently displayed at all registration counters, not just in hospitals, but in clinics and medical systems centers as well. The upshot of such a move, as the Life Insurance Association, or LIA, itself has allowed, is the possibility of removing healthcare provider panels. Such restrictions are inherently anti-competitive since panel membership is restricted by definition. With prices no longer the main criteria for panel membership, non-panel doctors will face more pressures to rein in their charges. And as the SMA has stressed, panels short-circuit the patient-doctor relationship. To contain cost escalation, insurers can simply agree to pay out amounts of between the 40th to 60th percentile, leaving patients a choice. Those who wish to do so may top up any of the excess charges at their own expense. We should also be sensitive to how more players in an industry, especially in health insurance, need not automatically give rise to the most competitive prices. For instance, allowing the exclusion of pre-existing conditions effectively consigns most patients to their current insurer, once such conditions are developed and identified. But if we value the inherent natural justice in taking care of the chronically ill and believe that competition among insurers will work to contain the inevitable increases in premium, then the government can resolve the coordination problem by mandating the carrying over of pre-existing conditions, because any insurer would never want to be the first mover. Moreover, competition may also be the most effective at containing costs when there's simultaneously a dominant player, in this case, the government, operating through MediShield Life, who takes on the role of the price setter. This requires MediShield Life to be even more proactive in negotiating and bargaining for lower prices for procedures and medications that it covers. After all, since the 3Ms account for less than a tenth of total healthcare spending, the value of these publicly mandated components of the healthcare system must rest in the ability of the public sector to either coordinate players or signal the direction that this pricing, that the system should follow. Such negotiated pricing is common in single-payer systems worldwide, including Canada, France, Germany, Norway, Sweden, and the United Kingdom. Relatedly, MOH should also scrutinize the face value of public charges. There have been anecdotal reports that pre-subsidy prices of some public health providers are now significantly higher than their private sector equivalents. While I believe that the public sector still bills less than the private sector overall, it is important that the regulator keep an eye out for unwarranted public sector charges. After all, when the typical patient will only be concerned with his or her actual unsubsidized fees, it falls, therefore, on MOH to police price escalation on paper, since these are benchmarks for the private sector. The Fee Benchmarks Advisory Committee should expand its scope to not just examining the overall fee schedule, but also interrogate any persistent or accelerating divergence in public-private fees. Finally, we should also be cognizant of how actions by the government beyond MOH may contribute to cost escalation. More than one doctor we spoke to stressed that the industry-wide need to raise prices was premised on increases in rental costs at private hospitals, and that this elevated benchmark was in turn first set by the president of Mount Elizabeth Novena. The cost of the $2 billion facility was compounded by the record-setting $1.25 billion land sale on which it sits. Here, higher land sales costs have translated into higher medical charges. The need to adapt to rising costs, of course, does not fall solely on the medical profession and medical facilities. Insurance often find it easy to pass along costs, which allow them to stack additional layers of paperwork to access insurance payouts. While I'm not in favor of interfering with how private firms run their businesses, additional administrative burdens undeniably lead to fee bloat, while also adding distance between the patient and the treatment that they receive. Here, the government can leverage information technology to roll out a central insurance claim system. MediShield Life claims are already directly submitted by CPF at the moment. However, IP claims are still independently processed by the respective insurers. This adds unnecessary steps and increases administrative costs. There's currently an effort underway to develop an integrated claims platform across insurers. Since there is already presumably a common claim system for MediShield Life, MOH could enfold this proposed claims platform under the same umbrella into an expanded public-private partnership platform. Mr. Speaker, I understand that the complexity of healthcare has made this speech more involved than usual. But my bottom line is simple. We allow the private system to grow sans public sector leadership and strong regulatory guidelines at our peril. My actionable takeaways are that we include greater cross-referencing of prices to benchmarks that are limited in range, that we allow insurers to pay out within this narrower range, and if we believe in the justice of covering pre-existing conditions, the government should play a coordinating role in mandating such coverage. Government should also be more proactive in bargaining for lower prices for procedures currently covered under MediShield Life, while also auditing excessive discrepancies between public-private fees. And as price increases in other inputs, such as real estate, should should be managed since this can spill over into healthcare costs. I'm sure we've all heard stories of how we've experienced long wait times for admission into our hospitals lately. Data released by MOH suggests that the median waiting time could have been almost 24 hours. The ministry takes the question of wait times seriously. Yet, researchers from the Saw Swee Hock School of Public Health note that despite measures to reduce waiting times, the problem and the concern persists. I will conclude, Mr. Speaker. I see your trigger-happy finger. My fear is that
my finger is not trigger-happy. I was just going to remind you that you have nearly breached your 20-minute full complement. That is your right. So could you wrap up, please?
Thank you. My fear is that such waits are but a foretaste of what an overstretched public health system forced to operate alongside a parallel private system with only light regulation could yield. That said, I support the motion.